Show of hands, how many of you guys do vertebral augmentation? Gosh. Look around. Put your hands up. Look around. All right. This is an absolute travesty. So let me tell you why. So I have fellows. Alvaro Bravo Martinez is going to be my next one. You can go ahead and feel sorry for him right now, starting right now. It's going to be a blinding speed of light, fire hose next year. It's going to, you'll love it though. My previous fellow did 697 patients, vertebral augmentation, and he is really good at it. So let me tell you why you're making a huge mistake not doing vertebral augmentation if you don't, or not learning it if you have the opportunity. If you go back 10 years and forward 10 years, number of osteoporotic patient population doubles. What I tell my fellows, if you don't like old people medicine, you better start liking it. If you go back, the boomers started turning 65, 2011. Prototypical boomer. Bill Clinton turned 65, 2011. And this is 10,000 people a day turn 65. You go back to 1964 to 2030, the increase is 4.2 times. We're impressed by things like diabetes, obesity, hypertension. Demographics pale in comparison with old people. The single thing, the most common fragility fracture by a factor of 2 is a spine fracture. 1 million a year in the United States. Each spine fracture is associated with a relative rate of mortality of 8.6 times age mass controls. That's Collie Osteoporosis International. There's 2 things we do in medicine that demonstrably saves people's lives. One is hip fracture repair. The other one is spine fracture repair. We wrote a paper this last year, we call it the NNT paper. Number needed to treat. Are you guys familiar with this statistical value? The number needed to treat. So during that paper, we gave some comparisons. And we know that doing vertebral augmentation is demonstrably life-saving and life-prolonging. On the average, it gives you somebody between 2.2 and 7.3 years per patient. Quote this paper from Ovid in Journal of Bone Mineral Research, 2011. The paper that we wrote, Kevin Ong was the first author, and we studied 32 million patients in the Medicare database, 2,077,000 fractures. We found that the rate of mortality was reduced 55% for those that underwent augmentation. The number needed to treat. So what's the number needed to treat to save somebody's life when you do a coronary angioplasty and stent placement from the same database? Does anybody know this number? It's too high to calculate. What about an aspirin for males over 50 to ameliorate symptoms of a stroke or a heart attack? So how many people do you need to give an aspirin to before you ameliorate symptoms of a stroke? The answer is 3,000. What about a heart attack? 1,667. How many people do you need to do vertebral augmentation on before you save 1 life at 1 year? 15. So how could you not do something that you're well suited for, given the fact that every 15 patients, Shannon, you're saving somebody's life, right? Amen. Amen. So I'm going to show you some approaches that are non-transpedicular. So the great Dr. Shanar is going to show you the transpedicular approach. I'm going to show you the parapedicular and the extrapedicular approaches. These are 2 approaches I originally described and originally developed. So these are something. I don't know about you guys, but I'm not good enough just to do a transpedicular approach. There are times I have to do parapedicular, and at times I have to do extrapedicular. I think while you were there, you saw an extrapedicular. We went around the hardware, and fractures happen all the time around hardware. So this will put 2 more arrows in your quiver, but my main point to you is you guys that don't do augmentation need to start. And as Dr. Stacy mentioned, there's nothing that he does that he learned in his fellowship the same way. I would have to agree wholeheartedly. There's hardly anything I do now, except for vertebroplasty, that I learned in fellowship, and maybe epidural injection. So it's not beyond you. Okay, so I'm very conflicted. That's my disclosure slide. I'll make fun of that in a talk in the future. So we're going to talk primarily about the para and extrapedicular approach. The parapedicular approach is not through the pedicle. The pedicle is about 1 centimeter to 1.5 centimeter tube of bone. You go outside the pedicle. You're accessing it in a convex surface. You can put big things in the vertebral body because you're not going through the pedicle. You're going from more lateral to more medial, so you get to the center of the vertebral body more easily. It's faster, transgresses less bone. Sometimes you can get a twofer and tag the medial branch of the dorsal ramus, denervating the facet joint as you go parapedicular too. That gives you style points. So this is something that we did with, hey, look at that. This is something we did using right there, yeah, between the nerves, and we took 11 cadavers and we painted the nerves in yellow, painted the neurovascular bundles in red, and this is the junction between the pedicle and the vertebral body. And here's everything labeled to give you a better bird's eye view of what this is. And this is our spot, right? And it goes between the nerves. And we start the parapedicular approach just like we start the transpedicular approach. It's 10 o'clock and 2 o'clock. Transpedicular approach, you go from that position, 10 o'clock, 2 o'clock in the pedicle, depending on if it's right or left pedicle, up 1 centimeter, out 2 centimeters. That's where you start for the transpedicular approach. And I'll show you where we start for the parapedicular approach. And these are the steps. I like everything in steps because it makes it easy. We're going to identify where we need to go, make the incision at a 45-degree angle. We come down. If you're confused about your antero-posterior location of the needle, you look on FOSS. A 30-degree oblique will help you greatly and will help you and the patient from hurting greatly later on. You switch to the lateral view, verify the position. You make sure never transgress the medial wall of the pedicle before you're in the posterior portion of the vertebral body. And that last sentence that I just said there is really the only thing that you need to know other than the start point to not hurt somebody. That's easy, simple. So on a line from ipsilateral superior to contralateral inferior vertebral body corner, you draw it up here and you take this width here and you go out that distance there. I mentioned the 10 o'clock position. Centimeter up, 2 centimeters out. This is the start point for the transpedicular approach. This is the same trajectory, just farther out. And the reason we gauge this from the size of the width of the vertebral body is because people are different size. What's the greatest determiner of size difference between human species? It's whether you're a man or a woman, right? Men's bones are bigger. And if you measure this on people, you will find that out. And then you start off 45-degree angle, you go down until you hit os, tap, tap, tap. If you get lost, you can turn to oblique. This is a 20 to 30-degree oblique. This is the pedicle. This is the equator of the pedicle. You need to be just in front of the pedicle because this is a parapedicular approach, just at or above the midpoint, the equator of the pedicle. Turn it back, tap, tap down, and you never transgress until you can always check trajectory too. So on this one is especially important. Before you tap all the way down, you want to make sure the trajectory is important because if this thing is really compressed down here or it has a dip or some funny anatomy, you want to make sure that needle is targeted to get to the very front of the vertebral body, especially if you're going to do a balloon kyphoplasty or replace a spine jack. So this is very important. Trajectory is very important. So you tap, tap down. The cardinal sin is you never violate that medial wall of the pedicle right there until, yeah, kind of. All right, so you never violate the medial wall of the pedicle until you're in the posterior portion of the vertebral body. That's the only thing you have to remember. You can't stay out of the neural elements if you do this. I've done 10,000 of these. I started in 1994 when I was 5 years old. I had to get up on a little stool. You know, I get up there and I was a precocious guy. So I've never had a neural injury that I've known about, never. Registry, 1,096 patients. We reported on 732 patients. How many neural injuries in the registry that we just finished? 0. So if you do this right, this is not, describing it as safe is inaccurate. You'd have to describe it as extremely safe for people. So Proper trajectory, this allows you to get to the center of the vertebral body on the AP and the lateral, and that's how you judge it. You're 50% of the way across on the AP and lateral, and this will allow you, as a perpendicular approach, to get into the center of the vertebral body. Again, tip, do not violate the medial border of the pedicle that's indicated by the small black arrows until you're in the posterior portion of the vertebral body that is indicated by the posterior wall right here and the black arrows on that. So this is thoracic cross-sectional anatomy. This is the costotransverse junction. This is the costovertebral junction. You can see how this goes here. Costotransverse, costovertebral. This is the path of least resistance. The reason why we have a costotransverse and costovertebral junction is because God wants you to do thoracic kyphoplasty. That's why it's there. So please feel free. Some of the pitfalls that we have is in the lumbar spine, the anatomy is different in the thoracic spine. Very difficult to go transpedicular, especially in the upper thoracic spine. People call it transpedicular. Functionally, we're not going. We're going parapedicular. When I started saying parapedicular, some people say, oh, you can't go parapedicular. There's too many neurologic structures out there. Number one, that's not true. We know that for sure, because we've proven it anatomically. I just showed you the cadaver images. Number two, for people, our colleagues that do adult deformity surgery, so 26 pedicle screws, right? All the way from, T1 all the way down to the ilium. Now, how do you think they get the pedicle screws in the thoracic spine? Do you think they're going transpedicular? No, these are parapedicular screws. So anybody can put a 3-5, 4-5, and even sometimes a 5-5 screw through that portion of the thoracic spine. You'll be able to put an 11-gauge needle there, no problem. So this is the original paper, 102 fractures in 72 patients. No nerve root injuries, hematomas, or anything, physical exam, CT, and we followed these things. These were consecutive patients. All right, so this is the modified inferior in-plate extrapedicular approach. This has also been published. Just look up my last name, you'll find both of these papers. And if you can't find free access to it, email me and I'll send them to you. The main thing for the modified inferior in-plate extrapedicular approach, or the extrapedicular approach, is to get around hardware. That's the main thing. If you haven't had a case where you have to get around hardware, you haven't done enough cases. You will need to do this. You will have to do this. And you say, well, I do a perpendicular approach. I get around the hardware that way. No, you can't sometimes. Big old 6-5 screw in a lumbar vertebral body, you can't get around it. So this is very useful to you. It's also useful in vertebral plana. Same thing applies. You can put very big things. Does anybody know what this is? This device right here is. It's a Stax device. It was 11 millimeters in longitudinal diameter, 4, and the other one is a rectangular shaped thing. And this could only really be put in para or extrapedicular approach. So here's the anatomy of it all. And this is kind of a funny approach. The way that I developed this is we did this in cadavers, but I did it in the cadaver because I was in Georgia one time and I saw one of my neurosurgeon colleagues that had this image up, an old plain film, Mylar, and I'll show you the approach in a second. And I said, why did you do it like that? I mean, that's a funny approach. He said, well, he was an old guy back then. This was probably 20 years ago. He was 70 then. He said, well, we always do it like this. So I thought, that's interesting. So you mind if I steal that idea from you? So my wife says I hadn't had a new idea since 1992, but I certainly can steal ideas from other people and publish them. So we did this, and we mapped it out how he did it. And it turns out if you're anterior to the neurovascular bundle, you're below the segmental artery, you're behind big red and big blue, and you're above the end plate, that's a very large hypovascular area, aneural and avascular. And so here are the steps. Very similar, with the exception we do 45 degrees for the lumbar spine, 30 degrees for the T-spine. We did this after assessing 1,000 consecutive CT scans, looking at what would be the appropriate angle. And I don't really like angles too much, but this is what we do. This is how we keep things safe. This is how we teach people. And so you identify the point, and whether it's 45 degrees in the lumbar or 30 degrees in the thoracic spine, you go down to the os. All right, so the appropriate final position in this will be halfway across in the AP and in the mid to anterior portion on the lateral. Okay, so what's important here, to get 30 or 45 degrees, you have to know what's directly AP. So you have to line the vertebral body up AP from the very inception. Make sure the spinous process is right in the center between the pedicles. Then you select your spot. 45 degrees is just anterior to the pedicle. It is just above the inferior end plate. Here's the pedicle. This is the inferior end plate, just anterior to the pedicle. And your target zone is this whole thing out here. Really, you like to keep it right here, but it's a big target area. And you come in, and it shows you, I'll show you a case around the hardware and some of the cases of vertebral planar where this technique is also quite useful. And tap, tap, tap. One of the tips here, you'll need to hold it with a coker or a Kelly, because you're going outside lateral to the multifidus, and multifidus tends to hold the needle up straight. When you get too far lateral, it doesn't do that. The needle will flop around on you. So here's an example of it on hardware. And the other important tip is whenever you come down to the osseous portion of the posterolateral vertebral body, that is not like a pedicle. You can, in very osteoporotic patients, it's sometimes even difficult to feel the cortex. The needle will sail through there, so just be aware of that. In very osteoporotic patients, that cortex at that part of the vertebral body is quite thin, especially in fractures. So this is an access. This is somebody that had a fracture, believe it or not, of that, even after augmented screws. So we needed to go in and augment that, and that's about the only way you can get around there. So again, the proper final trajectory is when the needle is in the mid portion on the AP and the mid to anterior portion on the lateral view. All right, so pitfalls. I mentioned the anatomic landmarks. Do not go back here, posterior to the pedicle on the fluoroscopic view. This is where the neurovascular bundle sits. These are the descending ventral rami. If you go posterior to the pedicle, both you and the patient will hurt greatly. This is a segmental artery. You can get pretty brisk bleeding if you stick one of these, but it doesn't appear to really matter too much. So I've gotten what I would term almost audible bleeding a couple of times with these big devices, but it doesn't seem to really matter a whole lot. There's really no hematomas or anything when we followed these patients consecutively, but just realize that that's there. And be smart. I said 30 degrees in the thoracic spine. Don't drop somebody's lung and then tell everybody else that Dr. Beall told you to go 30 degrees when the person is cachectic and they weigh 85 pounds, right? So if you're worried about transgressing the lung, common sense, go shallow, then tilt it up when you're in target position. That is one of the pitfalls in patients with a 30 degree in the thoracic spine. And very cachectic people, sometimes the lung will come in the way. And just try to avoid that segmental artery, even though it doesn't appear to cause any long-term downside or hematomas, at least in the patient population that we've looked at. I have had a couple of hematomas by doing that. So 30 and 45 degrees can only be estimated. Your C-arm is marked. Use it. And it can only be estimated from the starting point. If you're 20 degrees off, because a patient's laying like that, then 45 degrees is going to be 45 degrees from what is anatomically AP, not how you're holding the C-arm, focusing the C-arm on the table. Use a Kelly or a coker, because that needle is floppy and when the lateral starting point. And sometimes you won't be able to accomplish this. There are certain people that have really wide ribs, and you can't get below that rib. And mind yourself when you go below a rib, because the neurovascular bundle of the rib is there. Just be aware of that, all right? A pitfall. Second pitfall is this technique is generally not possible in the L5 level, because the pedicles are wide and it's hard to get around. And the iliac wing comes up over your target. So this extrapedicular approach, not possible at L5 usually. So 96 fractures in 72 patients. Again, no hematomas, no nerve root injuries, no compromise of any other kind. And that is it. Thanks for your attention. I'll open it up to questions or comments. Yes?
Are there good courses available if, you
Gosh, I don't know, Shannon. Would there be a good course or a course? I mean, yeah. So there are.
Specific for these, usually you have to be there.
Yeah.
For this.
Yeah.
And it's.
Well, we've done a course or two together, right?
Yes, sir.
Yeah, there are courses. So anytime you're interested in a course, just reach out. We have got to get you guys trained, right? Easy? I mean, we can't. These guys have to be able to do augmentation. So I mean, it's magic, miracles, and kyphoplasty, not necessarily in that order. I mean, if you were to ask my fellows that come through, they do a lot of everything: pumps, stems, spacers. I mean, everything. Vertebral augmentation is their single best thing, their favorite thing to do. You guys are really missing out. And augmentation done well is not the same as just doing vertebral augmentation. Rama.
So those are really cool pictures of the instrumentation and the extrapedicular motion. How did you know that was a pain generator, that level?
Well, it was bright on stir on the MRI, and it had a little fracture line too. I'm not sure, people say that pedicle screw and rod spanning and stabilization will prevent that. That is bunk. That is not true. So we measured in-plate deflection with spanning pedicle screws and rods with fractures in a lab in Switzerland. And you know what we found? We found the movement of the fracture was about the same after you spanned it with pedicle screws and rods as it was unspanned, untreated. So what really limits the in-plate excursion is augmentation. What limits it more is when you fill the vertebral body up with cement. What limits it maximally is what's called screw-assisted internal fixation, SAIF. So we put pedicle screws in, and you use something like a pedicle jack with spine jack, or you use stents, vertebral body stents that are not available in the US, but I've done a few of these, and you cement it in front, and you hold, the screws go through the pedicle, so it holds front to back. This is the king on stabilizing the spine. You can do Magral A 3.3 fracture or an AO A4 fracture standalone. You don't need to span it with screws and rods. You can do that. We just wrote a book on vertebral augmentation. It's going to be out in March. It's 51 chapters of awesomeness. So thank you for everybody contributing. You guys contributed to it. Thanks a lot for that. And so one of the things I did is I emailed hundreds of the best guys in the world, and these are the best guys, very, very best guys. Said, give me your fastball. I'm looking for a chapter, like 2 or 3 paragraphs, 2 or 3 images. Give me the best thing that you do, right? I don't care what it is. I'll put it in there, almost. So we had one guy, Stefano Marcia, wrote a whole chapter about treating Magral A 3.3 fractures with vertebral body implants, spine jack. So this is something you guys, it's really starting to take off. And I hope with the aging population, you guys would jump on board with this. There are courses, and ask representatives from Merit, Stryker, Medtronic that make the stuff to do this, and they will help you. And I would be happy to. I do courses. I do dozens of these courses a year, and I would be happy to have you there. Questions, comments? Yes?
Question with the extrapedicular approach that you do, because you're sort of more inferior, more caudal on the vertebral body. If you're inflating the balloon for the kypho, do you worry? Can you not inflate it as much as you would if you're doing more of a transpedicular approach because you don't have as much bone to kind of open up?
Yeah, so that's a good question. The answer is no, I don't worry about it at all. I don't worry about many things, especially not blowing the balloon up and along the inferior end plate. So 90% of the time, it's going to be the superior end plate that's fractured. When we've learned a lot about how end plates function when we have a combination of low compliance balloons and implants. So you'd think if you put a spine jack in there with a superior end plate fracture, that ski would go through the end plate. It doesn't, just pushes it up. The same with low compliance balloons. It provides kind of a foothold. The medium compliance balloons, the the Kyphex Expander 1s from Kyphon, formerly now Medtronic, were kind of medium compliance, and they would eke through little gaps in the end plate. Low compliance balloons don't do that so much. So once you get a nice flat surface, it really pushes it down if it does happen to be an inferior end plate fracture. And I do use this technique a lot for just that, this inferior end plate fracture. So it's a good question, but feel safe doing it. It doesn't appear to violate it for those reasons.
Can you
Yeah.
just describe your take on height restoration versus just getting?
So height restoration is absolutely important, absolutely important. What's the evidence? Jan van Meyerheg did the surgical free trial in 2013. He published it, and he said and it wasn't a height. To substitute the surrogate he measured for that in terms of reduction was the segmental vertebral angle, right? The difference between the top quartile in terms of pain, function, quality of life improvement and the bottom quartile, right? The very best and the very worst was 3 to 4 degrees in restoration of the sagittal vertebral angle. That's not much, but by doing it, where do you get the height? You don't get the height posteriorly, you get the height in the middle and the anterior portion, right? So the other thing too is Seiko's trial. Spine jack was shown to be better than balloon kyphoplasty in terms of pain reduction, height restoration, and adjacent level fracture reduction. So if height restoration isn't important, why do we have statistically significantly less adjacent level fractures with implants than we do with balloons? The other thing too, spine jack's a big device, right? 4, 6, and 8 gauge. So you're putting a 5 millimeter implant into somebody, and you say, well, I like to use less invasive things because it's kinder, gentler to the patient, meaning that it's less painful for them, right? No. The bigger device here not only was better in terms of pain, it was statistically significantly better in a little non-inferiority trial. But you know how hard that is to do? To have 3 superiority claims in a non-inferiority trial, especially with pain, right? My average pain scores in the Evolve trial, largest kyphoplasty trial ever done, as treated on label, similar to an FDA phase 4, my average pain scores went from a 9 to a 1.4. My mean pain score before and after kyphoplasty. That's a 7.6 point reduction in pain. Oh, that's an anomaly. That can't possibly be true. Registry, 6.7 reduction in pain. It's one of the best things that you'll do, for sure. Height restoration absolutely matters. So you have to be rethinking about what causes pain. So you're putting big instrumented stuff in to put an implant in the vertebral body. Should hurt more, doesn't. Hurts less, significantly less. So we have to be thinking about what causes pain more than just the invasiveness of the procedure. Okay, questions, comments? Yes?
In your experience, like in the community, who are the providers doing this procedure?
Radiologists, orthopedic surgeons, and neurosurgeons. Interventional pain, are you an interventional pain physician? So am I. What a coincidence. So, because I'm a radiologist and started off I'm not a newcomer to interventional pain. I've been doing it for a long time. And one of the things that the pain guys have a shortcoming in, radiologists have our shortcomings. We certainly do. Your shortcomings, you don't do enough augmentation, or even close to it. It's unacceptably bad. And with the aging of the population, it's a different world. And you need to start liking old people medicine. Ramos said that earlier. I think that's what you tell your guys, right? We have a geriatric patient population. I operate on people in their 90s darn near every day. So you guys are really missing the boat on this. You gotta learn.
As Dr. Beall is saying, is that in all the things that I do, I have to say vertebral augmentation, kyphoplasty, this is the most satisfying in terms of giving my patients relief of everything that I do, whether it be spinal cord stimulation, neurotomies, epidural injections. This is the number one. You'll bring a patient from being bedridden to up and walking in terms of the pain relief, and you see it on their face after they wake up from the procedure. person just being in such severe pain to you're bringing the life back into them almost. It's quite remarkable. I think my background is in physiatry with interventional pain management. This is part of my practice. Yeah, you might have to seek training with the number of companies and courses that are out there. And this is why, one of the reasons why we wanted this part of our armamentarium in this course, because this is the population that you're going to see. And I can't stress enough that please get involved, get to a course, because it's very helpful to your patient population going forward.
All right, guys, so we're going to transition over to the lab. I'm going to just pop over there. We're going to show you the 3 approaches for vertebral augmentation. We'll make that move now.